Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can find our previous episodes on Apple Podcast, Spotify, Google Podcast, and on your favorite podcast app. Transitioning children with rheumatic disease into adult rheumatology practice sounds really simple, right? You basically just give the child a different address to show up for their next rheumatology appointment. Unfortunately, things aren't always so easy, and not just because the EHR of the pediatric practice differs from that of the adult side. To discuss all the challenges of transitioning children to adult care, and most importantly, to discuss ways of facilitating this transition, I've invited Dr. Stacy Ardoin, a pediatric and adult rheumatologist at Nationwide Children's Hospital and Ohio State University. Dr. Ardoin led the American College of Rheumatology's participation in the American College of Physicians' Pediatric to Adult Care Transition Toolkit project, and she has published several research studies and reviews on this topic. Dr. Ardoin also serves as the director of the Division of Rheumatology at Nationwide Children's Hospital and as the vice president for the Childhood Arthritis and Rheumatology Research Alliance. Hope you enjoy the show. Stacy, welcome to the show.
Thanks, John. It's great to be here with you today.
So, some rheumatologists think that we make a really big deal about this transition stuff. All they want to do is make sure that the kids get to the adult rheumatologist and that the rest of it is irrelevant. Have you heard this criticism from colleagues, and do you think it's true?
I have heard that criticism from some people who maybe don't take care of the young adult as often as others. And I think there's some truth that the success is getting the patient to the adult provider. That's something we definitely want to do. That's a marker of us successfully taking care of a young person and having them make it into adult care. But I think it's just part of the story. In order for us to do an excellent job, there's so much more to it than that. And we know that the patients who make this transition from pediatric to adult care often encounter a lot of difficulties along the way or don't make it at all. And we need to do a better job of assuring it's smooth and that the youth and young adults thrive in adult care.
Yeah, and I think if we set the bar as, well, just making sure that the patients make it, oftentimes they don't even make it, right? I think some of the studies have shown that half the patients or so that get referred to adult care end up back to their pediatric rheumatologist and don't actually make the transition.
Yeah, that's so true, John. It's remarkably consistent in the series that have been published. It's about 50% sort of achieve what's defined as a successful transition, which is usually seeing the adult provider within a defined period of time, like let's say 1 year after their last pediatric appointment. Some of those do bounce back to adult care. Some of them, we don't know what happens to them. And some of them, unfortunately, a small minority, but more than they should, die during that transition as well.
So why is this transition thing so important?
Well, I think we have to remember that these young adults are vulnerable in so many ways. First and foremost, they are young adults. Their brains are not completely developed. They don't have full executive function. And yet, at the same time, they're being asked to understand a completely new system, negotiate it, often with limited parental or other help. And it's very complex. It's complex for us as physicians to manage these healthcare systems. For a 20-year-old who has many competing important priorities that often are not their healthcare, it often doesn't go well. And on top of that, there are insurance barriers, time barriers, and significant cultural differences between the adult and pediatric worlds that make it challenging for them.
Yeah, I think, most kids, if there's a child with juvenile arthritis, the whole care is managed by the parent, right? It's like, it's the parent that calls the office for refills, and it's the parent that schedules the appointment, and it's the parent that goes to the pharmacy and picks up the medicine. often it's the parent that's bugging the child every day. Did you take your medicines today? Right? And then in the adult world, we assume that it's the patient that does that. And I guess we don't realize that there's a big step from the care being managed by the parent to the care being managed by the patient.
Yeah, absolutely, John. It's super appropriate, let's say, for a 3, 4, 5-year-old who comes in to the clinic with juvenile arthritis for the parent to be the primary provider of medications and oversight. But as that child becomes older, let's say 14, 15, 16, up to 18 years of age, there really ought to be a period where this child, now young adult, is learning those skills for themselves. I think pediatricians often recognize that's important, but often struggle with how to make that happen in the clinic and how to foster independence in these youth. It's a transition for the parents, it's a transition for the patients, and it's a transition for the providers as well.
Talk a little bit about this idea of the transition for the parent. How can this be challenging for parents?
So I have 17-year-old twins. They're right in this age group where they're transitioning from adult care. And I've really had to step back myself and encourage my kids to make their own appointments or pick up their own prescription or certainly sit it out in the waiting room while they talk to their providers. And even for me, someone who's well versed in transition, sometimes that's difficult. And I want to be there, but I also want to give them their independence. I think for many parents, some of them are very eager to allow their children to have more independence, but they just don't know how. Like, what do I do? There are simple things that their care team can share with them that will help them. For example, how about next time you have your child call and make this appointment? Or simple steps like, how about if your child calls and requests the next set of refills? But for a parent, it's not often clear where to start. Then there are also some parents who are very fearful of letting go. Comes out of love, but also there's a need to foster independence that they need to recognize.
Right. I can imagine that fear, if the child has had, complications from their illness, now it's up to the child to just remember taking the medications. And if they forget, their disease might flare. I'm sure there's a lot of anxiety from a parent perspective about sort of this whole transition process. One thing that struck me was that we're talking about transition and you're talking about sort of early teenagers. Is that when we should start thinking about transition?
So there are some conflicting opinions on when we should start thinking about transition. I think according to many guidelines, it's either around the age of 12 or 14 years of age. I personally just view it as a spectrum. I treat a 6-year-old differently than I treat a 2-year-old, than I treat a 12-year-old, and really just trying to incorporate all along the developmental milestones, opportunities for the child to provide their own history, name their medications, connect with me independently. So it's really just more of a gradual development process.
Yeah, it's striking when you ask a teenager where it hurts. And mom answers the question is like, "Mom, how do you know where it hurts?" So this idea of the child becoming sort of the primary reporter of their condition is hugely important. And I don't know if do you have any secrets, any tools that you use in clinic to try to get the story from the child, or at least encourage the child to tell you what's going on?
So simple things first, always make eye contact with the young person when you're talking to them and ask them the question and not the parent. I mean, sometimes as pediatricians, I think we fall into the trap of always asking the parent. Another important thing is when they get a little older, it's really important to kick the parents out of the room for a little bit and talk to them independently. There, the child has no choice but to communicate with you directly because the parent is absent. So that helps as well.
Tell me how you do that. So is it sort of when you're going to do the physical exam, or how do you do that in your clinic?
My practice on that has changed over the years, and I would say it's a little bit individualized to the family. But what I try to do is start with my initial visit with someone who's usually in the age of 14 or older to tell them at the very beginning of the visit, hey, you're 14 years of age or whatever the age is. And I think it's really important for me to develop a relationship with you one-on-one. So at some point during this visit where it feels comfortable for both of us, I'm going to have your parent step outside the room and we're just going to chat a little bit and then we'll bring your parent back in. And it's just an opportunity for you to learn to share your voice with me and ask me any questions you might like to. Then I ask the parents and the child if that's okay with them. And it's really exceptional when to have anybody object to that. Usually people agree, but I think it's better to prepare them in advance that it's going to happen rather than just spring it on them in the middle of a visit. So that's what I try to do.
That's a great idea. I think I'm going to borrow that. And then what is it like? Do you ask them all the sex questions and the smoking questions? Is that what you do during that time?
Well, certainly you gotta ask those sex, drugs, and rock and roll questions, right? That's important. We certainly ask those, but I think in addition to that, I'm always just first asking them, "Hey, while I have you here, I wanna know if there's anything important for you to discuss that you don't feel comfortable bringing up with your parents or that you'd like to discuss in more detail that we previously discussed with your parents." And sometimes those things are the sex, drugs, and rock and roll questions, but sometimes it's something completely different about, hey, I really just don't like this medicine. Could we please figure out a way that I could be on a different medicine? Or I don't like it when my mom gives me my injections. How do I get her to let me do it myself? Or something along those lines. So I just think giving them a voice and an opportunity to prioritize what's important to them is really critical.
That's great. And then when you bring the parents back, debrief, like do you say, "Oh, so we talked about the sex, drugs, and rock and roll," or how do you manage that sort of the confidentiality between the patient and reporting to the parent and documentation, all those things?
Yeah, really good point. So one thing I didn't mention before when I had that conversation with the parent and the child about having this opportunity to discuss things one on one, I usually share that, everything we're going to talk about will be confidential unless, of course, there's something that comes up that makes me concerned about Johnny's safety. So when they come back, I will just say, hey, we had a great conversation, don't have any big concerns. And if there's something that we need to talk about further, we'll just bring that up and talk about it.
So we talked a little bit about, the skills that children need to gain in order to have a successful transition. We talked about sort of reporting about their symptoms. You mentioned a little bit about calling to make appointments, calling to get refills. Any other skills that you feel are important for these children to learn before a successful transition?
Sure. So one other one is that our nurses help us out a lot with, and our pharmacists as well, is can you name your medications and do you know why you're taking them? Do you know what some of the important side effects are? So that's something we have a lot of help with in our clinic, which is nice. And I also ask the kids, I want you to treat me like I'm your friend that you want to tell about your disease. And I want you to tell me about your disease. So why don't you tell me about lupus? And just make sure that they have a little bit of the pitch that they're able to explain their condition.
That's great. That's very important. In some of the readings that I've done on this topic, they talk about self-efficacy, sort of the ability to manage their condition. How do you assess or teach, self-efficacy? How do you think about that?
So self-efficacy is a really important concept. We've studied that in a couple of our small research studies we've done looking at some validated measures, including one called the patient activation measure. It does tend to correlate with measures of transition readiness, which is another concept. I think in the real life clinical world, I don't usually use those specific tools, although we have developed a transition readiness measure at our institution that's loosely based off the GOT transition tool that has been developed by Patience White and her team.
Yeah, well, we'll talk a little bit about that later on. So it sounds like we need to think about transition early on, try to get the child to become sort of more of a manager of their own condition as opposed to the parent. And what's the role of the pediatric rheumatologist in this process? Like, what should they be doing?
So I think it's a pediatric rheumatologist, but I also expand it to the care team. I think we're fortunate at our facility that we have, nurses, social workers, pharmacists, psychologists engaged. But I think at every center, there are certainly nurses involved who can be active participants in this process. Our job is to make sure we're paying attention, I think. So we're assessing these patients, seeing where they are with being able to complete the tasks that they'll need to be able to complete successfully by the time they reach adulthood. And we need to be assessing that readiness on a regular basis, whether you do that through your interview, whether you do that through a structured questionnaire. I certainly think that can be different at every site, but it's important to do that. And then I think taking opportunities to promote that independence is important. So once kids reach, 14 to 16 years of age, I'm often at most appointments asking them to identify some activity or goal that they want to accomplish by the next visit. So what is something you want to administer your own Humira injection one time, or you want to call and get that refill, or you're going to send me a MyChart message, asking me a question, making sure you know how to use it. I think taking those opportunities along the way helps to develop the self-management skills.
That's brilliant. I love that idea, giving them a little bit of homework assignments for them to have it ready for the next visit. So when should kids transition? Is it 18, 21? What's your practice?
Yeah, that's certainly an eye of the beholder, isn't it? So I believe in Canada, it's 18 and you're out, and there are other institutions that have similar policies. Our institution is a little bit more flexible. We aim to have people transitioning to adult care by the age of 22 or earlier, but there are certainly are exceptions for children with complex neurodevelopmental conditions or those who have trouble finding appropriate specialty care in the adult model. At our institution, we try to transition kids to adult care by the time they are either completing their education or initiating employment or, you know, adult relationships, childbearing, those kinds of very adulty activities when they're adulting,
When they're adulting.
starting to adult.
Yeah, I'm still trying to figure out if I'm adulting or not. But that makes sense. In Boston, we sort of do the same thing because we find having them get a pediatric or an adult rheumatologist in college, sometimes that's very challenging, especially if they're out of state. So we also usually keep them until they graduate college and are setting up, their new life in a new city and help them transition at that point. So we've spoken a lot about sort of what happens in the pediatric world with the child, with the parent, with the pediatric rheumatologist, and the rest of the staff. Now let's look at the adult rheumatologist. What's the role of adult rheumatologists in the transition process? Or what should the role be?
So you and I are both adult and pediatric rheumatologists, so we have one foot in each camp, so we can speak on both sides of this issue. The adult rheumatologist obviously is going to be the primary caregiver and potentially could be the primary care provider for even longer than the pediatric rheumatologist is, depending on if they stay in the same location. And the rheumatologist, I think, one of the vulnerabilities at that time of transfer to the adult care is the rheumatologist really has a great opportunity to get to know the young adult in a personal way and make sure they feel connected to care so they are wanting to come back to that provider. They're going from a provider that they've maybe known for 5, 7, 10, even 18 years and developed a relationship with, and then stepping into an office with someone they don't know. So that very first visit is just really critical. So I think the adult rheumatologist really needs to be cognizant of that and take efforts to develop that rapport at that visit. And then also, I think the adult rheumatologist really needs to be aware of the vulnerabilities of this young adult and be prepared for those roller coaster rides of young adulthood that can happen and be there to support the young adult. This young adult may need more support than an older, more mature patient along the way. I like to encourage the adult rheumatologist not to be afraid because it's a really exciting time of life and these are fun people to work with and they are going through exciting times in their lives. So I find it a really rewarding group of people to take care of.
And should the parent attend, that first rheumatology appointment with the adult rheumatologist or not, or patient's preference?
I think that's completely up to the patient and their family. But I think the expectation setting needs to happen at that visit, whether or not the parents are there, who will be the primary person to communicate with the provider moving forward.
And what responsibility does the adult rheumatologist have in trying to sort of better understand the child's rheumatic condition and, previous therapies and, should they communicate directly with the pediatric rheumatologist or just look at the chart? What's the ideal?
So I think in the ideal world, the pediatric rheumatologist has done an excellent job of creating a very nice curated summary of the young person's experience in the pediatric rheumatology clinic. And by curated, I mean not 275 pages of printed out lab results, but a nice summary of critical information, including some personal aspects of the young adult that can allow that adult rheumatologist to show that they've paid attention, they've read what the pediatric rheumatologist sent, they're interested in them as a person. On the other hand, if an adult rheumatologist doesn't get that information, I think that seeking that information is a great idea. So just call your colleague, phone a friend and say, hey, I need 5 minutes with you to talk about this patient. Certainly review the records. But as we all know, reviewing, 27 epic encounters is not always as good as communicating directly with your peer.
That makes a lot of sense. And sometimes, this idea of like obtaining records sounds so easy, but, I've worked in hospitals that I can see one hospital across the street And just getting the records from one place to another is truly challenging. And what do adult rheumatologists need to understand about pediatric diseases? Like, what are the highlights? Is JIA all the same thing? Is it just RA in little children? Or are there specific nuances about pediatric rheumatic diseases that are important for adults to realize?
So before I get to that, I want to go back to one thing you just said, John, which was about the sharing of information. So I found the most foolproof thing to avoid the problems with data transfer is just to give the patients a copy of your summary letter and records for their own, to travel with them in their hands. So that's my little pearl. But talking about pediatric diseases, so certainly there are a lot of things that are very similar, particularly with polyarticular rheumatoid factor positive JIA, which some people may, including your colleague, Peter Griffith, may say is basically RA. But there definitely are certain aspects of pediatric rheumatic disease that I think the adult rheumatologist needs to be aware of, particularly with JIA, focusing on some of the complications that can occur, which we all know, including uveitis, which can continue into adulthood, and then the regional growth disturbances like micrognathia and TMJ involvement, limb length discrepancies, and all of those. In the setting of other diseases like lupus, I think adult rheumatologists can sometimes underestimate how aggressive pediatric lupus can be. So being aware of how severe that disease can be. And then I think there's a real opportunity for improved education about some of the other pediatric disorders, like, for example, our autoinflammatory syndromes or others where adult rheumatologists just may not have as much experience because many of these conditions have been recently described. So there are great opportunities for collaboration there.
Yeah, and for learning, I guess, I'm sure in some of these autoinflammatory diseases, I feel sometimes the patients know more about them than the providers. They may be one of a couple that have been published in the literature, and certainly their experience is much better than that of me or other physicians. Tell me a little bit about, this age, sort of the teenage years or young adults, reproduction and reproductive health play a large role. And what are your thoughts about sort of the importance of reproductive health during transition?
So when we've done a little bit of research talking to transition age youth, this, particularly for females, but also for males, is a very high priority. Often they feel it's not really addressed directly. So I think it is important to address it directly, both for pediatric rheumatologists and adult rheumatologists. And a lot of times we think we're a little bit squeamish, particularly on the pediatric side, about discussing this, but I don't think the patients are uncomfortable typically with these discussions. So again, in a private and confidential space for the teen or young adult, it's important to, one, assess their goals. So one of those is pregnancy intention. I think, assessing whether a young woman is interested in becoming pregnant is critically important. And sometimes I would promise you, if you ask, you'll be surprised by what you hear. So it's important to know. And you won't know if you don't ask. But if they are interested in pregnancy, then that leads to a conversation about safety of medications and timing. And if they are not interested in pregnancy, then that can lead to a conversation about what might be appropriate to prevent pregnancy if they're sexually active. That is also something that's very fluid, so needs to be reassessed pretty much at every visit, I would say.
And from adult rheumatologist perspective, what should the office have in place, or should the office have anything in place in order to facilitate the transition, from pediatric to adult rheumatologist?
Yeah, that's a really good question. I would say ideally we should have some things in place, but I would say it's probably the norm that there aren't resources specifically available for this population. So in an ideal world, I think it would be optimal to have a social worker who's available to address the concerns and knowledgeable about the concerns of this young adult population. I would say that's quite variable across institutions.
So, it sounds like a great idea to prepare the child, prepare the parent, prepare the adult rheumatologist. Are there systems or guidelines to try to help, put these into practice? Because, we say that rheumatology patients need vaccines and we show the data, but yet many of them aren't getting the appropriate vaccines. This all sounds great, but how do we actually get it into practice? And how do we get, our everybody from the pediatric rheumatologist, adult rheumatologist, how do we get everybody involved in the goal of a successful transition?
So, great question. I think there are many different models out there. And one approach I particularly like is, as I referred to earlier, is a program that was developed by Patience White called Got Transition. So many people know Patience White is actually an adult rheumatologist who developed a real keen interest in young adults and teens, and has really been a fierce advocate for these people. And she's developed expertise not just in rheumatology, but across all ages for helping with the transition to adult care. With federal funding, she's developed many resources for patients and families and also has facilitated research in this area. If you haven't checked out her website, I encourage you to do so. There are recommendations and resources there for patients, families, caregivers, every type of practice you can imagine, whether it's a pediatrics practice, primary care practice, adult practice, specialty practice, med peds practice, how to incorporate elements of successful transition into the care. And it's really based on sort of some core elements, like, for example, assessing transition readiness or measuring specific responsibilities. But the idea is that you would just take these core elements and customize how you develop interventions at every center based on the local environment. So it's very flexible. And we found that to be really helpful at our center.
Would you care to elaborate more a little bit about either your center or other centers that have transition practices and how it looks, throughout the sort of the process of transition?
Sure, I can probably speak most eloquently about what's happening at our institution. So, one of the elements of the GOT transition is to develop a transition policy, very simple. So, we share a transition policy, which is pretty broad, just stating that we plan to develop self independence by the age of 22 so that the youth is able to transition to adult care, and that these are some of the things that we will do along the way, such as speaking directly to the child independently, et cetera. So we share that policy with the families at age 14, beginning then, and then annually thereafter. The next phase is that we assess transition readiness using the tool that I mentioned that our institution has sort of developed based upon the GOT transition tools that are available. And we assess that readiness using an iPad based application that links to the EHR, where the patients answer those questions once a year. And it tells us whether they are comfortable doing an activity or they feel like they need help or want to learn. And it keeps it pretty simple. I think it's important not to overload people with too many questionnaires. And then also assesses how important is it for them to move on to adult care. Then we kind of develop interventions based on their responses by our social worker, pharmacist, and providers, ultimately hoping that we get them to a point where they're feeling ready in all accounts by the time they transfer. At the time of transfer, we're sort of intensifying those activities, and we're also developing this curated medical summary for them and for their adult providers. We haven't done all the things we want to do, but that's sort of a bare bones look. There are lots of other models out there, as you know, John. One is to have a separate transition clinic where people go from pediatric to a separate clinic before adulthood. I think that has some advantages and some disadvantages. It's another set of transitions and changing providers, but it can also be helpful. And then there also are some clinics where, like, the adult providers will come over to the pediatric, or pediatric will go over to the adult institutions. I think there are a lot of different ways that people can accomplish this.
That sounds awesome. So it sounds like, at least in your practice, you're putting a lot of effort in helping this transition. Are there funds for that? Like, for the social worker, all these things take time, probably take some money. iPads aren't free, right? So where are you finding the funds to fund this project?
We've done these under the guise of quality improvement, and we're fortunate that our institution provides a lot of support for quality improvement activities. So we use funds from that. There are some opportunities to bill for some of the transition services, although I would say that's not going to gain you a tremendous amount of of revenue for these services. I think you sometimes do have to get creative. There are also opportunities to develop things that are shared amongst divisions, which obviously lowers the cost. So I think there are a lot of creative solutions that may be out there.
Moving on a little bit, this whole transition is sort of its own discipline. How should we teach trainees about the transition process, and what is it that they need to know? Do they have to go to your practice and see it in practice, or how should we teach this for trainees?
That's a great question. I don't think it's really too much a part of a curriculum, and we don't have a standard curriculum for this. It may be interesting for some person out there listening to develop one. That would be helpful. So some eager young investigator or educator, that would be a great project. But I think the way that our trainees are going to learn the most is from our role modeling as supervising providers. So I think we need to be mindful of that. I would direct people to the Got Transition website, and then recognizing that this is an important area. I think there have been many more publications, presentations at national meetings. Organizations such as the American College of Rheumatology have developed efforts in transition. So has the Childhood Arthritis and Rheumatology Research Alliance, or CARA. So I think those opportunities exist for people to get engaged and learn both at their own institutions and beyond.
So what's next? Like, what questions do you think remain unanswered in this whole transition business? If you had a large NIH grant, where would you put your money and your interest? What questions do you still have?
That's a really good question. I think one of them is just the compatibility of the electronic health record, which would solve so many problems beyond transition, but would also really help with transition and developing portable way to share this information. I think from a research perspective, this is a challenging group of individuals to study because they are often changing health institutions, and tracking them from one to another can be challenging in order to assess outcomes. Also, because the diagnosis codes can get very confusing at this age. As you know, like a person with JIA will often be coded as RA or whatever. So it's really difficult. I've often thought there could be some really interesting projects like, we're making efforts to combine large registries to assess these transition outcomes. So for example, could we link the CARA, the Childhood Arthritis and Rheumatology Alliance registry, with the RISE registry for the American College of Rheumatology, and really see how these patients do over time and sort of identify those that we really need to focus our attention on. That would be really helpful.
I think, this idea, sort of system-wide research, both to assist the transition and then to study it, is probably pretty high yield stuff. Let me ask you another question. How did you become interested in this whole transition business?
So that's a good question. I was trained in internal medicine and pediatrics. So I think just the very nature of that training makes you interested in both sides of the coin. But I really do remember a patient I took care of in fellowship. My first year of fellowship, I think it was my third month in, and I can see her so distinctly, her face. So she was seeing it, I think she was, I want to say 19 or 20 when we were seeing her at my first visit with her, and she was preparing to transition to adult care. She had lupus. She was doing well at the time, and she was going to transition to a local provider because she traveled, I think, 3 or 4 hours to come to see the pediatric rheumatologist. Then about 4 months later, I took care of her again on the adult side, where she was in the intensive care unit, very sick, hadn't had any care in that interim, had ended up with an amputation of her leg because of antiphospholipid antibody syndrome and very active lupus. And there were so many opportunities to help her that didn't happen. And I think that was one of the stories that got me really interested.
Wow, powerful story. Yeah, I think for me, it's certainly a similar interest of seeing those gaps, right? And being able to identify the gaps and trying to see if these systems can help address those gaps have also been very important. Great. Stacy, this has been a wonderful conversation. I've certainly learned a lot and plan to use many of the tips that you mentioned with the patients that I'm seeing this week. I think for a lot of the resources that you mentioned, we're going to put them on our website. So if anybody's interested, they can go to acronair.org and check out the Got Transition. And Stacy, if you want to provide us with any other materials, we could also put them in our website. It's been a wonderful conversation. Thank you so much for your time.
John, it's been wonderful talking with you, and thanks to ACR for this opportunity to highlight the importance of transition.
Awesome.
Take care.
Take care. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this episode at acronair.org. I hope that this discussion enhances your ability to manage patients that are transitioning from pediatric to adult care. I certainly learned some pearls from Dr. Ardoin. Until next time, stay healthy.